to consider, what type of graft solution is needed depends on the case that we're working on. Not every case will be approached the same way. As we saw, Dr. Kim presented some beautiful photos and cases of patients with varying degrees of bone deficiency or soft tissue deficiency, one or the other, or a combination of both deficiencies. So when we think about bone grafting, it could be this video here on the lower right side where we are doing an autogenous block bone graft in the anterior maxilla, and then 4 months later on the upper right side we're retrieving the bone fixation screws due to a deficient buccal lingual bone area in the anterior maxilla, or over here on the left side where we're doing a lateral window sinus floor elevation. These are all cases where we're considering bone grafting materials, and for me in my practice, I like to keep things simple. Dr. Ed was talking about keep it simple a lot yesterday and this week. So simplicity matters because of your workflow in your practice. If you have, dozens of different types of bone grafting materials in your practice, sometimes it can feel like you have what you might call a choice paralysis, where you're not sure which material to use, which one is the best one. And of course it's good to be prepared for any cases that may require different bone grafting materials or methods, but I do follow the keep it simple rule, or what we call the KISS rule, and it just helps be productive in practice. So today we're going to focus on some more fundamental properties of bone grafting, and this is not as high level of a topic as what we've discussed this morning so far, or even yesterday, but sometimes it's good to remember the fundamental building blocks of what it is we're doing. So this should be a review for a lot of us, but sometimes it's good to review it together. So 4 different classifications of bone grafting. There's an autogenous, which is coming from us, allogenic, which is coming from the same species but a different donor. Xenograft is from a different species, and synthetic is going to be created. So there's 3 different properties to consider, and not all 4 types of bone grafting categories have all 3 of these potentials. And with osteogenic potential is something we're very interested in. We want to be able to generate bone. Also, osteoinductive potential is going to be something we consider with allograft, and osteoconductive potential will help us create a foundation or a matrix to build bone and have a pathway of where to grow the bone and to accelerate bone formation. So some basic properties of autogenous grafting is historically been considered the gold standard, and for a lot of good reasons. We know that autogenous bone is highly accepted because it comes from the same patient. And so technique is important to consider. The first slide that I showed, you saw a couple videos where we used block grafting on the anterior maxilla, and we were placing those screws that you saw me placing into the bone. And then in the upper right video, I was removing those screws. Those screws are important because we want to immobilize the bone graft so that way it has a higher chance of success of integrating into the recipient site. So graft mobilization or graft mobility can be the kiss of death. So earlier we talked about the black triangle being a kiss of death for aesthetic failures. This would be a kiss of death if you have graft mobility. The graft will have a much higher chance of failure if it moves, and we want to immobilize it. So autogenous grafting is a great way to regenerate bone, but it's not without its disadvantages. So already implant surgery is creating injury to the surgical site. When we consider an autogenous graft, where are we going to take the graft from? So sometimes it can be the ascending ramus, the external oblique line angle, the anterior mandibular symphysis, or the maxillary tuberosity. Those are all possible autogenous bone grafting donor sites. But we have to consider what are the postoperative consequences of taking bone from those donor sites. Then there's allogenic bone graft. This is our main workhorse, or the main type of category of bone grafting that we're using in my practice. And I really enjoy using this graft material because it's very predictable. Once you use this material frequently enough and you develop your own sense of comfort with using this graft material, you'll see what works and you will see what does not work through practice and use of this grafting material. So what are the benefits of allogenic bone graft or allograft? Well, it's great because we don't have to take the bone graft from a donor site. This comes packaged, sterilized, and is vetted for predictability and that it would work. Also, it has this property of osteoinductive potential, meaning it has growth factors that come from the cadaver donor for the bone graft. Osteoconductive, meaning it has a matrix form to the graft material, which will help guide the osteoblasts and osteoclasts and osteoprogenitor cells to lay a foundation for new bone formation, for woven bone and lamellar bone. There's also notable that not every tissue bank that provides you bone graft is considered equal. Every bone grafting or tissue bank company has different standards. They have most common standards are going to be infection control, but the quality of the bone graft that you receive from the tissue bank can vary from company to company. Another type of grafting material is xenograft. So this can be porcine derived or bovine derived, or even algae or coral or even wood. Wood's a type of xenograft. I haven't personally used any of those types of sources for wood xenograft, but I thought it was interesting in preparing for this presentation that wood was a source of xenograft. So it's just basically osteoconductive. You won't really see any benefit with osteoinductive potential, and definitely no osteogenic potential from either allograft or xenograft. And then there's synthetic grafts like calcium phosphate, glass ceramics, and these can be very beneficial for economical considerations, or maybe just because there was a small defect that didn't need a whole half cc of bone graft. This could be a good solution just to do some minimal repair. So in some cases, you might wonder, why would we bone graft at all? And Dr. Kim was mentioning yesterday, I believe, about Dennis Tarnow's research on when to graft and when not to graft, and you can find an advocate for almost any philosophy you want to follow, but it doesn't mean that they're always going to be what's best. So bone grafting, in my opinion, is a wonderful service that I can provide to my patients, because if I can help facilitate more bone growth, then why wouldn't I? I want them to have a successful, fast healing, and bone grafting is a wonderful way to achieve that result. So there are studies that do show there are significant collapses in bone after a simple extraction. So one study they did where they researched post-extraction bone changes in dogs and found that there were significant changes in buccal lingual bone deficiency after an extraction. So, bone grafting is something that can preserve the shape and the width of the edentulous site and help make future dental treatment more predictable, whether it's going to be an implant or a fixed partial denture, a 3-unit bridge, or a removable prosthetic bone morphology is going to be preserved with bone grafting. So especially in the anterior aesthetic zone, this was a study that I found was very interesting that was considering the maxillary anterior buccal bone thickness. And this study said it was measuring on the cone beam radiograph, the thickness of the buccal plate in cases that were equal to or less than 1 millimeter in thickness had a significant association with bone collapse without a bone graft. So in other words, considering a case where an anterior maxillary tooth is extracted, like a central incisor, and the bone thickness being less than 1 millimeter thick on the radiograph, removing the tooth and not grafting has been associated with a higher chance of buccal lingual bone volume collapse. And so those are higher risk cases where you definitely want to consider bone grafting to preserve the ridge shape. And that ties into the phenotype Dr. Kim was talking about earlier, considering not only the soft tissue appearance, but also, what's the bone morphology look like? Those are all considerations with soft tissue phenotyping. So back to basics of healing. So we have 6 phases to consider when a tooth is extracted. So first, obviously we know there's going to be socket filling with blood. Then a clot forms, which forms a matrix. So the clot forms that matrix, and that helps recruit the cells that are going to come in and start breaking up the fibrin that are in the clot, laying down a granulation tissue framework, and then that will set the stage for the next step 4 here with the vascular network, connective tissue forming, and then connective tissue starts to eventually turn into woven bone, which is the immature bone, and then we know that becomes into lamellar bone as it becomes more mature and complete healing. So that's the normal process. And with allografting materials, this is one of the bone grafting material families that are offered through ZimVie, which we get all of our grafting from ZimVie. The biomaterials are very high quality. We've used bone grafting from companies that are not affiliated with ZimVie before, and I've been surprised that I do see variability in the bone grafting quality from different tissue banks. So each implant company has a different source for tissue banks. Sometimes they share a common source, sometimes they don't. And a lot of times they advertise, this is the cheapest, this is the lowest cost bone graft, very great, same thing that you get from here to there, it's the same thing, and that's what they want to tell you, that it's the same thing, but it's not the same thing. It's very important to do your research on where you purchase your bone grafting from, because the way that they process and test the bone grafting material matters. So one of the reasons I love buying my bone grafting from ZimVie is because I know that they test all of the lots or the batches of bone grafting before it leaves the facility to go to your office. And so one of the ways that they test it is they can do either a biochemical assay, an ELISA assay, or they can plant that bone grafting material in a rat's thigh muscle, and they monitor it to see over weeks and weeks of time, does it form bone? And so they make sure that every batch of bone graft that leaves the tissue donor bank can do what they're advertising it can do. And if any grafting batch doesn't pass either the biochemical ELISA, the assay, or the in vivo study, they throw away the whole batch. They don't send it. So in other words, what does that mean on a clinical practice level? That means that in my office, I know that the graft I'm using has a higher chance of success. as long as the patient's body decides to do what we're trying to let it do, because ultimately the patient's body will decide whether or not it will accept the graft material. The patient's body will decide whether or not the implant will integrate, and there's a lot of factors that I can't control, but I can help have some control over where I get my grafting from, and that's why I choose this grafting company. So there's also my favorite family of graft to use from ZimVie is the Puros allograft tissue, because it has the sterilization process for taking from the cadaver donors, and it's a much gentler process of sterilization. So both of these have very effective sterilization processes. This is the Regeneros allograft material, and they both use the oxidative treatment and acid washes and the low dose gamma irradiation to sterilize the tissue from the donor banks. But the Puros uses a proprietary method called tutoplast, which is going to be a lot gentler of handling for the tissue. So they both get the job done, but my favorite is Puros because I like the handling characteristics of the graft as we're placing it into the extraction site, and also I like the radiographic appearance. I can see where my graft material is after I complete the grafting procedure. We always take a radiograph after that so we can see where the graft fills, and it's one of my favorite to use. So this is our typical recipe. To keep it simple, we're using a 70-30 mix of Puros cortical cancellous allograft, and for most of my cases, if I'm doing a graft, then I'm usually either using a PTFE or a non-resorbable membrane or a collagen membrane, but it's just more important for me to get primary closure when I'm using a collagen membrane. And when I'm using a PTFE or a non-resorbable membrane, it's less critical.